Hi everybody, my name's Kate Williams. I'm one of the trustees of the Society of Tissue Viability. I'm a lecturer at the University of Huddersfield and an honorary tissue viability nurse in Leeds community. Today we're going to discuss the mobility part of Purpose T. So as you know, the focus this year for Stop the Pressure campaign is risk assessment, and the focus is particularly on Purpose T. So I'm joined today by two amazing colleagues who are going to help me pick out the importance of that mobility section and the role of the AHPs generally in risk assessment. So I'll let them introduce themselves. Sarah?
Hi, I'm Sarah Seager. I'm a physiotherapy lead in the Neighbourhood team in Leeds Community Healthcare.
Helen?
Hi, I'm Helen Stebbings, an occupational therapist with the assessment and rehab team at St James's.
Lovely. So I've got a few questions just to go through. So the first one would be, how do you feel AHPs approach that mobility section on Purpose T differently to nurses? Helen?
I'd ask the person to get up and show me what they're capable of doing, look at how they're managing day to day, focusing on the daily occupation, so physically seeing them moving about.
Yeah, it's rather than just a question.
Yeah.
Yeah. And from a physio point of view, Sarah?
Yeah, so I suppose if I'm seeing somebody doing a Purpose T, it's because they need to see a physiotherapist, so that they've got a problem moving around. And I guess, like Helen says, we'd see them moving around, and I think the thing is, rather than just asking how much do you move, we'd then be asking why. If they can't move very much, why can't you move very much, and what are we going to do about it?
Yeah, I think from my experience, sometimes AHPs are a bit more about fixing the problem rather than just identifying the problem. So do you think that nurses could refer into AHPs a bit more to try and reduce the impact of that mobility section, or of the person's mobility on their pressure ulcer risk? Do we use you enough?
Yeah, I think we're an integrated team with the community nurses. That's changed since we integrated, that we get a lot more referrals because we're working together and we're having them conversations more. And I think it's more about that, actually. So you're not moving, so I'm going to do something about it, rather than just also ticking the box that doesn't move often.
Yeah.
And
people are acknowledging that if somebody's more active in the day-to-day life, they're getting up to use the toilet, they're getting up to make cups of tea, that sort of thing, that's going to have a massive knock-on effect to the pressure risk. So I think there's a much more MDT approach because of the integration.
Yeah, it's easier, isn't it, to talk to each other?
Yeah.
So on Purpose T, the wording is on the mobility section, it says slight position changes or major position changes. So what sometimes I've heard nurses struggle with exactly what that means. So what's your take on it from an AHP point of view? Sarah?
So I would say a major position change is where you're getting your weight off. I mean, this is my own definition, getting your weight off your bony prominences. Although once you stood up, you stood on the bottom of your feet, not your backs of your heels, aren't you? So then you're moving around and the pressure's off all of them areas, but whenever you're sitting or lying down, there's some pressure on some bony prominence somewhere. So then I'd say position change is when you can take some pressure off an area, but not completely.
Yeah, like we're all leading.
Yeah.
Like a little demo. Would you agree with that, Sarah? I mean, sorry, Helen.
Yeah, and I think it depends on the person. It's very subjective because somebody in a wheelchair, their ability to change the position is very different to somebody who can get up and walk about. So it'd be dependent on what the person's physically capable of anyway. So somebody in a wheelchair, it might just be wiggling the bum. But that's quite a big position change for them, whereas somebody who can roll over independently in bed. I think it depends on the person, but as long as they're offloading and they can do that throughout the day, I'd be quite happy with that.
I suppose the other aspect as well is, because I've gone down the line of bony prominences, but if you've got somebody who's in a wheelchair and hoisted, if they go from sitting in a wheelchair and they're hoisted into lying in bed, then that's a major position change, isn't it? Because the weight's going through different bits.
I think the important thing, I suppose, from what you're saying is just to know the patient, isn't it? And know what's big for them, and is that enough? Does their skin look okay? you know, it's not just about ticking a box, it's about how it fits in with them.
Definitely, yeah.
Lovely. So thinking about the wider MDT or even people's relatives, how can other people help improve mobility?
We were talking before, weren't we, about people being too kind and wanting to do everything, and for the relative or as a carer doing everything. So maybe like definitely getting the patient to do more for themselves, and like getting them to get up and go make the drinks for people when they visit, or getting them to open the door and collect their own items for washing and dressing. So getting them to be as active as possible during the time that you spend with them.
Yeah, walking to the dinner table is a big one for me.
Yeah.
Rather than just bringing people food on the tray on their lap, if they just small things.
And that has a massive effect on not just the pressure also risk, but also like the way that they're engaging with people around them. It's more normal to sit up and eat your dinner at the table, isn't it, from a posture point of view? So I just think it has a knock-on effect. If you're getting people walking about more, engaging more in normal occupations, it affects the whole person, not just the pressure risk, which is really positive.
Yeah. Sarah?
Yeah, so I think as well, I think like Helen said about getting to come and take part in activities, but I suppose if they've maybe got dementia or they can't get a meal, can they at least stand up while that person's there on that visit and have, even if they just stand up or if they walk to the
look out of the window
with you, walk to the kitchen with you and watch you make the cup of tea. I think I think in particular people with dementia, although people with dementia tend to wander quite a lot, but then it's important not to stop them doing that as well, because that, as like Helen says, that's part of how they're coping with that.
So it's building in movement into every kind of contact possible, isn't it? Even if it is family popping in for a cup of tea, and can the patient stand up safely while you're there?
Physical activity as well. The more physically active you are, there's lots of health benefits to that. Although, if we're talking about people who are either moving a little bit or not at all, a little bit better than nothing.
Yeah.
I was going to say something else. So then you're also increasing circulation. So then you're improving skin condition anyway. So it's, it's not just about taking that pressure off that area. There's all sorts of benefits. And obviously people, when you think about the risk of falls, but then that's about thinking about things holistically, isn't it? And looking at it within a holistic MDT approach.
Lovely. I love this question because I've seen the impact of this quite a bit, but do you think that sometimes clinicians can make it more difficult for people to mobilise with the equipment that we give them? So specifically pressure relieving equipment. So if a cushion or a mattress, do you think how we choose that, we need to consider how it might negatively impact on someone's ability to move independently?
Yeah, definitely. I think repose mattresses can cause more problems sometimes, especially if somebody's struggling to get in and out of bed. It makes the bed that little bit higher, but also it's an uneven surface, so they tend to wobble, and if the balance is not so good anyway and they're relying on pushing up from a solid surface to stand, that can make it really tricky. But also from sort of how people, if you're sharing a bed with your partner and then you can't cuddle in bed because you've got this repose mattress on, it affects things like that. So people's quality of life as well. And then if you're using a cushion on a chair, it can affect your sitting posture. So people end up sacral sitting, so then it's putting the pressure in a different place. And if they're finding it more difficult to get in and out of the chair, they're less likely to get up as regularly as they would normally. So yeah, there's a lot to consider really when you're giving equipment.
Yeah, I've seen some of the cushions we give out can be quite thick, can't they?
Yeah.
So if I've seen sometimes where, if they only just get on, sometimes the patient can actually lean to one side more, so the whole weight distribution can be worse, can't it? How do you think we can get around that?
I'd be talking more about getting up and moving about rather than just giving equipment to people straight away. See if you could put a care plan in about more regular movement. And then if that doesn't work, look at alternative pressure relieving equipment, because if they understand if we've got capacity around the wrist, then it'd be better to have that conversation and get them more active.
Yeah.
Yeah.
Or if the equipment is affecting their posture, there are other pieces of equipment available that you can try or source or escalate it to specialist services to try and help you get more specialist care. Sarah? About mattresses.
Sorry, I put me on. I think as well, in terms of how can we improve that, is about understanding. I think I work with nursing colleagues, maybe probably less experienced nursing colleagues, who were like, oh, you sit in your chair all day, I'm giving you a cushion, and there's no other thought process to that. It's just, you need a pressure relieving cushion because I'm doing this pressure risk assessment, and that's going to reduce your pressure risk. And I think it's about actually that understanding that you then need to check that cushion, you need to look at the person first and think, well, they're already struggling to get in that chair. If I make it higher, it's going to be too high. But then also look at it after you've got the equipment in and check, can they sit okay in it once it's there, and can they move around okay. And the same with a bed. If you put in a mattress like overlay on a bed, can they still get in and out of bed okay, and can they move? And then asking, it doesn't necessarily mean they need to see a physio or OT, but then asking for advice if they think that equipment's not working and having that conversation.
Yeah.
The other thing for me as a physio is when people have the repose boots or heel pro boots on, and the nurses say, oh, you need to wear these all day, all the time. Always. And then I'm like, but you need to get up. I'm trying to get you up and walking. And then you can only walk when I come and take these boots off. So then actually you're sitting all the time. And it's about that. I have like 2 or 3 patients on my caseload at the moment where heel or foot wounds are an issue because they've been told to keep the weight off it, and I'm trying to get them mobile again after a fracture or an injury or something. And I think that's about an MDT approach. So I'm linking them with nurses and podiatrists about them patients to say, look, this person needs to be walking some of the time. Sit in a chair all the time.
We all think about our own little bit sometimes, don't we? Like the wound or the foot, and you're thinking about the mobility, but then when we all talk to each other, we can come up with a much better plan. Because the poor patient's stuck in the middle of this sometimes, aren't they? Getting conflicting advice.
Yeah.
So it can be quite difficult. I think one of the things for me is alternating mattresses can sometimes have quite a negative impact on someone's ability to move themselves. So all these pieces of equipment are fabulous on the right person at the right time.
In the right environment.
In the right environment, exactly.
Absolutely.
So if we're giving equipment out with the best of intentions, we have to think, actually, is it making them less independent? Is it affecting their posture? I've made the decision before to not give alternating mattresses. And it's worked out better for the patient because they are able to move themselves in bed, whereas with the mattress they're in and they're stuck. So it's very patient specific, isn't it? But I think that's part of the thing for me, is moving away from the actual ticking of boxes on a purpose T and just looking at that patient, your patient in front of you, and their whole situation with all your colleagues, isn't it?
I think that sums up the difference as well between a physio and an OT and a nurse, in that a nurse look at, say, right, you're not moving, you're at risk of pressure, so we'll give you some equipment, which isn't, I'm not saying that's what all nurses do, but a physio and OT mindset would be, you're not moving, why aren't you moving? Let's get you moving.
Yes.
That makes sense. And then think this equipment might help you move. We'd look at a completely different point of view, I think.
Asking the patient what are their solutions, how are they going to manage this risk, how are they going to manage this issue. So putting it back to them, really using your coaching and your self-management approach to get them to solve their own issues and unpick why are they sitting so long. So it could be something as simple as they're a bit lonely, they're a bit down in the dumps because they've been stuck in the house for weeks and not seeing anybody. So how can we solve that? And then they're going to be getting up and moving around more.
Yeah, if someone's frightened of falling.
That's a massive one.
Why they're not moving. Brill. I wanted to ask you as well, how do you see the role of AHPs generally in pressure ulcer risk management? So not just the mobility section, but sort of maybe looking at skin or the whole risk assessment.
So I think as AHPs, it's part of our role to reduce the risk of harm to patients, whatever that harm might be. And I think although traditionally it's not been a role, I think particularly in a community setting, or an elderly setting at least, it's everybody's role, isn't it? I've lost my words in it.
Yeah.
It's part
know
of
what
everybody's
you mean,
role
yeah.
to reduce the risk of harm, whatever that harm might be, whether it's falls or pressure or something else, like you know, safeguarding and things like that. I think depending on the setting, our roles are all going to be slightly different. And
Yeah.
I know that when we started in the team that I work in, we started doing the full purpose tea and doing the skin checks. It was a bit of a big change for us. But then it actually is better for the patient, because they just, if they don't need to see a nurse for anything else, and I've ruled out that risk and reduced that risk of pressure risk, then there's less people coming in the house. And
Yeah, because AHP is looking at skin in some areas that would be a completely new thing. I know in Leeds have been doing it for a while now, but like you say, at first
it was a big change, wasn't it?
It's a big change
For physios. I don't know for a OT point of view if it says
Yeah,
big
I
change.
think doing the actual assessment, that was quite new, but you'd always check somebody's skin over, you know, when you're doing a shower assessment or a self-care assessment. And I suppose that's quite natural, isn't it, that you're in there with them anyway, you're seeing them in quite a private moment, so it fits well with that. But going in and asking separately, that was new. But I do think, like Sarah's saying, it fits because you're not putting that person through more assessments than they need.
Yeah.
And hopefully, we're reducing the risk for that person. So that's positive, isn't it?
Yeah, it is much more natural, isn't it, for an OT to look in the shower rather than a nurse look late and say, can you take your trousers down?
Yeah.
Just spontaneously. Yeah, it's much more normal in your situation. That's brilliant. I think the concept of HPs looking at skin might be new to some people, but hopefully we've got them thinking. But I just want to thank you really for your help today, and hopefully we've lifted the lid really on the mobility section of Purpose Tea. Thank you both.
Thank you.
Welcome, thank you.